Hello and good evening, one and all, for yet another exciting Kera Grand Round session. This is the third session of Kera Grand Round. And as we decided about this format of Kera Grand Rounds, the idea was that we discuss relatively complex cases, case-based scenarios, and not theoretical talks. And we have our experts gurus who can guide us through cases, and that was the concept of Kera Grand Round. Today's Grand Round actually highlights the entire concept, what we were thinking about, a relatively difficult subject which will be dissected by our loved gurus out here, and who will be able to tell us nitty-gritty of a subject which is usually not so easily understood by everybody. So without further ado, I would invite Dr. Paras to take over, and we are really looking forward for this fantastic session today. Over to you, Dr. Paras.
Yeah, thank you, Himanshu, and I welcome all of you to this Kera Grand Round session 3. It was very interesting to choose a subject because we were wondering that what to cover in microbial keratitis. And then we thought of, the panelists and the group decided that, okay, we would just focus on a very rare entity in microbial keratitis, that is stromal microsporidiosis, not even keratoconjunctivitis. I'm very happy to say that today our host institute is Arvind Eye Care Center system, and we have, great panelists with us, like, with me today, Dr. Manoranjan Das, who is a chief moderator from AEC, would be taking care of, these sessions. Dr. Manoranjan Das is a medical consultant and cornea and refractive surgeon in cornea and refractive services at Main Center, Madurai. And we all know that he is, a Tendulkar of, Madurai. Most of his students, love him by his teachings. We have the other panelists from the same, from Arvind, are Dr. Revati. She's a chief cornea and refractive surgery services at Coimbatore. Another one is Dr. Anita Venugopal, who is a chief cornea and refractive surgery services at Tirunelveli. We have the other two, cornea consultants from different institutes. One is Dr. Meena Lakshmipati from SN Chennai, and the other one is Dr. Bhupesh Bagga from LVPI Hyderabad, who is very well known by his Bugbuster, meetings. The best part of this meeting is we do have, microbiologists also with us. We have Dr. Ram, a senior and chief microbiologist of, Arvind Hospitals, who is working at Coimbatore, Dr. Ram. Unfortunately, today, because of some social reasons, Dr. Lalita couldn't join us. So we are going to miss her. With this brief introduction, I would like to, say a few things about how we are going to proceed. Like, we would have 2 cases first, and then we would have some questions, and then followed by another 2 cases and some questions. And then we are going to push Dr. Ram's talk in between, so that we have a microbiological aspect to this disease entity. And then we would have the other 3, cases together. So all the cases are wonderful cases, and that is why we diverted from our routine, pattern of, Kera Grand Rounds, having only 4 cases. We have accepted all 7 cases which were submitted, and all of them are unique cases. And we are going to really have a visual treat looking at those cases and listening to the stories. So, we all know that corneal microsporidiosis behaves many a times as, we cannot differentiate it from, at times, from disciform viral keratitis or some peripheral ulcerative keratitis. So it is going to be a very interesting session today. So with this, I would like to invite Dr. Manoranjan Das to take over and initiate the session. Thank you.
Thank you, Paras. So at the outset, I would like to thank the Cornea Society of India to giving me this opportunity and giving all the Arvind Eye Care system a role to play in this small role. So I would like our first speaker, Dr. Radhika ji, is a senior consultant and the deputy director of the SN for the cornea services. And please go ahead with your presentation, madam. Great.
Hello, I'm Radhika from Shankar Netralaya. Stromal microsporidiosis keratitis can be a severe and stubborn infection. It looks like a lot of other microbial keratitis, therefore there's a delay in diagnosis, increasing its morbidity. Let us see the case at hand now. The patient was a 65-year-old male who had compromised vision in his left eye for a long time. But after some vague history of injury, the left eye has been uncomfortable for the last 3 months. He was diagnosed elsewhere as having viral keratouveitis and was on treatment with a cocktail of medication including soft steroids. As you can see in the picture on diffuse illumination, there was a large epithelial defect. There was dense stromal infiltration from the anterior to the posterior cornea, and there was surrounding corneal edema. Superiorly, the fluff in the stroma was a little lighter, but it extended almost up to the limbus. You can see the slit picture in the right showing the infiltrate is almost nearly full thickness of the stroma. Corneal scraping was done and it showed plenty of tiny oval fluorescing microsporidial spores on calcofluor stain. The chitin in the cell wall makes the microsporidial spores appear very bright, even though rarely fungal spores may also look like this. Plenty of such tiny spores were also seen on acid-fast stain, showing the typical rice grain appearance as you can see in this picture. PCR for HSV1 and 2 was negative. The patient was started on topical PHMB eye drops 10 times a day, along with oral albendazole 400 mg 2 times a day and supportive medication. Acinetobacter hemolyticus was also isolated in culture and was sensitive to gentamicin, which was added to the treatment at this point because we were not sure of a secondary infection. The eye remained status quo for 4 more days and the patient had severe pain and inability to sleep despite painkillers. Therefore, a therapeutic penetrating keratoplasty was planned and done for the patient. The excised corneal button also showed plenty of tiny acid-fast microsporidial spores. No other organism was seen or grown. The early postoperative course, there was a wound gape, however there was no leak and it healed spontaneously. Early suture loosening happened. The patient was started at the beginning of the 2nd week on topical lotipred eye drops in a tapering dose, and the PHMB and fortified gentamicin were continued. And later the patient developed large epithelial defect, so BCL was inserted, lotipred was changed to clear steroid, and since there was no recurrence of any kind, the fortified gentamicin eye drops was stopped. Later, when all the loose sutures were removed, a tarsography was done and the PHMB was stopped with continuation of only lubricating eye drops. The graft epithelialized well. It was obviously edematous. Once the epithelium healed, the BCL and tarsography were removed, and at 1 month follow-up there was no recurrence of infection and the patient was asked to come for vision rehabilitation after a few months. Thank you.
So excellent presentation, madam. So first of all, we'll take finish the 2 cases and then we'll start some discussion. Second case, Amrita, please.
Hello everyone, welcome to Kera Grand Drops 3. I should be discussing another interesting case of microsporidial stromal keratitis, which is misleading and mischievous. My first case is a 51-year-old farmer with complaints of blurring of vision, redness, watering in his right eye for last 7 months and was diagnosed as HSV immune stromal keratitis elsewhere and was using cycloplegics along with tobramycin and acyclovir ointment with a BCVA of 20/80. On slit lamp examination revealed corneal stromal edema along with infiltrate and nummular scars or footprint scars at the periphery with well-defined grayish-white KP adjacent to the infiltrate. His left eye also revealed peripheral nummular scars which looked inactive. So on the basis of The clinical diagnosis was made as HSV immune stromal keratitis, and the patient was started on prophylactic doses of acyclovir along with topical steroid 8 times a day. This is the day 7 picture where the cornea was relatively clear and the PCV improved to 20/30 and the stromal edema decreased and the topical steroid were tapered at this point of time. This is a picture of day 21 where you can see the cornea clarity at the center has improved, but the density of the infiltrate increased just adjacent to the center. So the patient, although he was very little because he was symptomatically better, was scraped and it revealed microsporidial spores. And at this point of time, topical steroids were stopped and the patient was started on PHMB 0.02% hourly. At day 28, here you can see the infiltrate has increased in size with the hypopyon. Maybe this might be because of stopping the topical steroid. And at this point of time, voriconazole 1% hourly was added. This is the day 38 picture where the infiltrate remarkably increased with increase in hypopyon. At this point of time, he was advised for the therapeutic PK, but because of raised sugar, it was deferred. At the same point of time, there was reactivation of nummular keratitis in his contralateral eye as well. So this is the day 60 picture where he was advised for a therapeutic PK. So the points to ponder here is how common is microsporidial bilateral stromal keratitis and how to differentiate it from HSV. My next interesting case is a 47-year-old liberal who had similar complaints in right eye, but for last 12 days and was diagnosed as uveitis and was treated with cycloplegic alone with a BCVA 20/60. On examination, it revealed mid-stromal infiltrate with very conspicuous large mutton fat KPs, as you can see over the slit view. And the infiltrate was much deeper, so endoscoping was advised, which revealed no organism, and the patient was treated with voriconazole, thinking about a fungal keratitis with an endoexudate-like picture. This is the day 10 picture where there was a new foci of infiltrate, and at this point of time, we planned the patient for a corneal biopsy, and the smear revealed microsporidial spores and the patient was started with PHMP hourly. You can see how conspicuous and large these KPs are. This is a day 21 picture where surprisingly the AC inflammation has reduced. And this is a day 28 picture. The patient was on PHMB alone. And here you can see along with cycloplegia, the AC inflammation has remarkably reduced with decrease in the infiltrate. This is a day 41 picture where you can see only presence of few pigmented KPs along with vascularization and scarring in the cornea. This is the 3 months picture where the patient have stopped PHMB 2 weeks back. Only few pigmented KPs at the center with a well vascularized corneal scar. So with this case, point to ponder is how common is such a fulminant AC reaction with microsporidial stromal keratitis and whether there is any role of topical steroid in these cases. Thank you.
Yeah, excellent presentation. The two cases are totally different. Dr. Radhika's presentations and the case was totally clinically different. The pictures from your stromal keratitis is quite obvious, but still the degree or the suspicion that came to your mind is really is difficult to come for all of us, because I could have also thought about this viral etiology first. So we'll discuss about this, and first of all, I would like to get some inputs about Radhika Madam's case. And can Revati Madam give some inputs about Dr. Radhika's case?
Thank you, Manoranjan. Radhika's case is usually that is the last presenting stage, I could say, because usually they'll be, when they were being treated as viral, the picture will be a little different as the next Amrita's case kind of thing. But suddenly they will become fulminant like this, typical necrotic full thickness abscess kind of thing. And that is the stage, definitely, like even scraping can reveal. If it is only mid-stromal, even scrapings will be negative only. Only clinical diagnosis, clinical suspicion we have to proceed with, or we need a corneal biopsy. But this is the stage often we see as the end stage. they present, and then it's really commendable that immediately they thought of microsporidial and with the scraping and found it. And at this stage, I think invariably only the surgical intervention will help. At that stage, the medical management, when the medical management is not at all, none of the drugs are proven, and I don't think in this stage it will be useful. And another point what she made, even though there is a small reinfection kind of thing on the host side, by continuing the medication and once we reduce the infection load, it responded well. That is another thing we have to keep in mind. We need not say that this prognosis is very bad in these cases. That is about Radhika's case. The other two cases, they are also really, really good. Especially the second one, I'm really happy about knowing, happy to know that it responded to the medical management. So far, even in our experience, only 1 or 2 responded like this. Most probably because it's more superficial and also near the limbus, probably. That is one reason. But otherwise, easily it can be mistaken for a disciform viral keratitis, the initial picture. And about the bilaterality, even our case presentation is also going to be a bilateral case. And it has been reported, but very, very rarely. It can come. And about the possibility why it comes as bilateral, I'm going to ask the other panelists also the possibility.
So one question from my side, Dr. Radhika. Madam, you started with the albendazole 400 milligrams BD. So how many days you need to continue like that? Because nothing is absolutely proven, but still you have given according to some literatures are already written. So if you give 400 milligrams albendazole along with the PHMB, so how many days you need to continue this albendazole tablets?
Is she there?
Dr. Radhika?
Madam,
I think she has lost her connection. Can we
Usually,
just move on?
like we can go, generally we have given up to 3 weeks. But albendazole and another similar group, another one also. But I don't think, personally, I don't believe these drugs really have any effect on this parasite. I don't think.
And
maybe Dr. Baga can
yeah,
share his experience.
Dr. Baga, are you there?
Dr. Bhupesh and Dr. Meena, I just have a question for both of you. That what clinical signs would you... His connection is not functioning well. Dr. Bhupesh, you are not well connected, it seems. Dr. Meena, would you like to comment upon, when would you suspect, possibility of microsporidial stromal keratitis? Because most of the time these cases are treated as viral, disciform or, immune-mediated keratitis. And by the time they reach us, they are pretty late. And many a times we don't even think of, scraping them and, checking for the microbiological workup. So what are the classical, signs you would like to, look for, or you would suspect that this patient could be having, microsporidial keratitis?
So it's a rare condition. So it's not very common. That's the first thing. So in India, we have more of bacterial and fungal keratitis. So that's why we think of them first. But that apart, the red flags for a microsporidial stromal keratitis is these patients have a white eye because most of them are on steroids. If you feel the eye is inflamed, that means the patient has just stopped using steroids before coming to your OPD. And these patients, most of them are on soft steroids because it gives them a lot of comfort. The epithelium is intact. And they have a dense white infiltration in the midstroma. And they can be well bordered or they can just about be very fuzzy. So one of the things that they can get confused with fungal keratitis is that they have satellite lesions. But believe me, none of these satellite lesions have the hyphate edges. They're slightly crenated, but they don't have the hyphate edges. Most often have their epithelium intact, they're midstromal, and very little minimal edema. But the moment you check their drops, and that's the most important thing, you have to check their huge packet of drops, and you will invariably see that these patients are using some steroids because that's what is giving them comfort. And they have been going on for months to months to months. So one question to what Dr. Amrita showed was one of her patients probably was recently pseudophakic. So one question is, was the patient recently operated for cataract surgery, and after which the patient continuously used the steroid because he has the extra amount of steroids in his hand. So that is one of the culprit. The patient undergoes steroid and retains the steroid drops at his house, and he keeps on putting these drops. So for me, anything which is epithelial intact, mid-stromal, and patient using some kind of drops, very few patients that I have seen have epithelial ulcerations. Little bit endoexudates, few of them with KPs, and very few with multifocal. If they are multifocal, they're fuzzy. They're like cotton wool appearance. They don't have a hyphae edge, they have a cotton wool appearance. And these cases, I am 100%, I mean, I'm 90% sure that they are thing. And before I treat them with HSV keratitis, I would almost and always want to prove microsporidiosis, especially if this patient has already visited 3 or 4 doctors, which is the case. And when you sit in a hospital like a teaching institute, they have already been to other institutes, and there's no point again subjecting them to antiviral therapy.
Yeah, in fact, Dr. Amrita's cases had, nummular lesions in the other eye also. So would you consider having, both the pathologies, like, probably patient had microsporidial associated with some, viral element?
Yeah, so I think their group is very active in proving that there is adenoviral component also with microsporidiosis. And if these are nummular lesions, in the case of microsporidial, they don't have uniform appearance. If these are uniform appearance, most likely these are adenoviral. I'm yet to see uniformly appearing nummular lesions as microsporidiosis. And if the patient is on steroid, I think the first thing is to rule out microsporidiosis. I think she has other interesting experiences with describing how the epithelial keratitis becomes a stromal keratitis. I think that's another day.
I would like to ask, if I am permitted, I would like to ask Amrita one question. The bilateral case, was there any systemic comorbidity in this case?
No, Dr. Revati, the patient was like a young patient, 54-year-old patient, and does not have any comorbidity. This we have a series of patients of stromal keratitis, 5 of them had bilateral involvement, and the other eye, which has a milder involvement, usually have this nummular scars, and usually they are present at the periphery. So I don't know the relevance of it, but I think going forward with this species identification can be useful, in this case. So,
Amrita, you did not scrape the nummular lesions, but you termed it as bilateral. So I'm not sure if this was proven bilateral, although it is just, I would say, it's a suspected bilateral, isn't it?
Yes, agreed.
Yes,
agreed. Just because we have
your comments.
Yeah.
Dr. Das, can I just add something? I kind of got cut off in the middle, sorry.
Yeah, yes, madam. I had a question for you, please.
I know, I'm so sorry. The internet connection was unstable, so I'm connecting back on my phone. So the thing in my mind is exactly what Dr. Revati and Amrita said put together. The way I understand, I may be right or wrong, that in the early stages of microsporidiosis keratitis, we hardly see them as a tertiary care institute. I'm sure you agree. But if we are lucky enough to see them early, there are 2 or 3 points which may arouse our suspicion. First of all, these are multifocal. Unlike a fungal ulcer where you have a main ulcer and a satellite lesion, these you have 2-3 balls of infiltrate in the stroma, which are approximately the same size, multifocal lesions. And I've seen that these lesions are more whitish in the early stage as compared to early fungal infection, which are more yellowish. So that is the second point that I have noticed. Third point has already been highlighted that these quite often lack an overlying epithelial defect. So if we see them early, the multifocality of relatively the same size and whitish discoloration without an epithelial defect, with a history of either injury or exposure to contaminated water, may raise a suspicion. But like Revati ma'am rightly pointed out, when it has crossed that stage, either because of chronicity or use of steroid or something, then you get the dense yellow stromal infiltrate when you cannot distinguish it from other lesions. And on the question of microbiological identification, I'm sure Dr. Ram, who's the expert, will talk about it later. But the little knowledge that I gleaned from this case was our lab at least uses KOH calcifluor as the primary modality of diagnosis, because the chitin in the spore wall kind of lights up with the calcifluor. Normally, we think that PCR or molecular tests are more important to diagnose difficult or different kind of infections. But Dr. Anand, who's our chief microbiologist, he tells that in the case of microsporidiosis, because only few species PCR is available, other species may be missed out. We don't have a general PCR for Microsporidia. Second is, the spore is difficult to crack open. So if you're using conventional method, the lysis may not be adequate and the PCR may miss it out. So in our lab, we use calcifluor KOH. Of course, acid fast stain also highlights that rice grain-like appearance, which I showed in my presentation. These are 2 points I wanted to make.
Yeah, thank you, madam. Thank you. So we'll go to the next topic of day. And the next topic, I'll hand over to Paras to invite the next.
Okay, we can move on to next 2 cases, Shabina. We have pre-recorded presentations, so we can run both and then we can have questions.
Good evening. Today I'll be presenting a case of bilateral stromal microsporidiosis. A 50-year-old female, uncontrolled diabetic, hyperthyroid, presented in August 2017 with redness, watering and diminution of vision in the right eye for the past 9 months. She had visited multiple hospitals and was treated as a case of bilateral viral keratitis with a secondary bacterial infection in her right eye. On examination, right eye showed full thickness necrotic infiltration with areas of corneal melt. Left eye showed diffuse subepithelial keratitis. Scraping in the right eye came positive for microsporidia on gram stain. Confocal showed small, bright, discrete bodies suggestive of microsporidia. B scan in the right eye was within normal limits. Patient was seronegative for HIV, HBsAg and HCV. In view of impending perforation, patient underwent therapeutic keratoplasty in the right eye 4 days later of presentation. Patients are simultaneously started on chlorhexidine and fluconazole eye drops hourly. Button culture came as cladosporium. Histopathology showed the presence of microsporidia up to the descemet membrane. Meanwhile, left eye stromal granular lesion was increasing in size. As bilateral microsporidiosis was suspected, corneal biopsy was advised, but the patient refused. About 6 months later, she consented and biopsy confirmed microsporidia. Hence, she was started in the left eye with topical chlorhexidine and fluconazole eye drops hourly. Therapeutic DALC was performed in the left eye. Postoperatively, the eye remained inflamed. About 6 months later, patient developed a graft infiltrate which was positive for microsporidia on scraping, and hence she underwent a therapeutic penetrating keratoplasty. About 1 year later, patient had trauma to her left eye, developed hyphema with high IOP and underwent AC wash. Subsequently, the graft failed. Discussion. Microsporidal stromal keratitis has a chronic, slowly progressive course, is often misdiagnosed as viral keratitis or fungal keratitis. Our patient also was treated as viral keratitis for 9 months before she presented to us with necrotizing keratitis in her right eye. Although MSK was suspected in the left eye as well, biopsy was delayed as the patient was reluctant for the same. Bilateral MSK is rarely reported in literature. Only 1 case has been reported by Garg et al. This adds to the uniqueness of our case. Uncontrolled diabetes might have predisposed our patient to develop bilateral infection. These are few of the previous studies on deep stromal microsporidal keratitis that have shown a long duration of symptoms for about 1 year before the diagnosis is made. Topical PHMB, chlorhexidine and oral albendazole have been used for medical management as these are antiparasitic agents. Antifungals like itraconazole, fluconazole and fluoroquinolones have been used as well. Fumagalin has been used in microsporidal keratoconjunctivitis. However, majority of these cases needed surgical intervention for successful eradication of infection from the cornea. Thank you.
Excellent.
It was a very nice case by Shweta Gavankar from Arvind, and we can go on with the second case by Dr. Sheetal Nanawal.
28 years old female presented to us with redness and watering in left eye in 2017, treated outside with topical and systemic anti. On ocular examination, right eye was normal, left eye had visual acuity of 618, lids were normal, conjunctiva had follicles, cornea, stomal haze and coarse SPKs, pigments on back of the endothelium. Corneal sensation was reduced, AC had reaction cells. Rest of the entire segment was corneal scraping negative for microsporidia, confocal microscopy suggestive of microsporidial keratitis. Patient was seronegative for HIV, HBsAg and SCV. We put her on chlorhexidine hydrop hourly, fluconazole hourly, tablet fluconazole 150 mg BD and topical. Patient went outside for higher study till September 2019 where she treated as viral keratitis. She presented to us in October 5 with bilateral flat top SPKs. Conjunctival smear in right eye and corneal scraping left eye positive for microsporidia. 1 week later, she presented with the visual acuity 1/60, stromal necrotic lesion, large capes and second. TPK was done. 2 weeks post-surgery, graft was clear, IOP control, visual acuity 6/60, scraping and conjunctival swab positive for microsporidia in both eyes. In last visit, March 21, patient had visual acuity 624 improved to 612 parts. Graft was clear. Lens had opacity. As patient was compatible with her left eye vision, advised to wait for any further surgical intervention. Next case, 56-year-old male patient presented to us with pain and redness in left eye since 1 week. He has referred from outside to us to rule out any microsporidial keratitis. Visual acuity in and anterior segment in right eye was normal. Left eye had 618 parts improved to 612. Conjunctiva had circumcorneal congestion. Cornea's central active stromal haze 4/4 mm, microcystic edema, and corneal sensation was reduced. Rest of the anterior segment was normal. Left eye conjunctival smear, no evidence of microsporidia. Confocal suggestive of microsporidia. ASOCT done to evaluate the depth of the lesion. Corneal biopsy, keratitis with post-inflammatory hyalinization. After 2 months of treatments also, lesion increasing in density, KPs were present. Left eye therapeutic DALK done. Post-DALK left eye visual acuity 636 to improve to 618. IOP was controlled, lamellar clear graft and DM well opposed. Take-home message was, microsporidial stromal keratitis is a rare entity. Its insidious course with symptoms ranging from 2 months to 2 years. Stromal lesions are often confused with viral keratitis. Late diagnosis is very common as shown in first case. Early diagnosis with thorough investigation and proper management is the key of control of pure visual prognosis and high recurrence rate. As depicted in first case, due to irregular and long follow-up, patient had more recurrent episode and underwent surgical intervention after long period as compared to second case who went surgical intervention in short span of time with good visual prognosis. Our study highlights the necessity of timely laboratory diagnosis, regular follow-up and importance of early surgical intervention as soon as the diagnosis is done. Thank you.
Very nice cases by both the, fellows from Arvind. There are many questions on the chat box as well. And here, before we take those cases, questions, I would like to ask Dr. Revati that what is the protocol of, medical management being followed at Arvind? Because I see, different drugs being used at different places. So do we have a standard protocol by now? Or what are the newer drugs which are being tried? Dr. Revati and Dr. Bhupesh both can answer one by one.
To be specific to your question, after handled a handful of microsporidiosis keratitis, I'm really doubtful whether any medical management is of any help, either drops or systemic. We tried, because it's being a kind of a parasite, we tried biguanides and some literature shows voriconazole or voriconazole. Fumigalin, of course, we couldn't get. So all other things, albendazole, we tried. Everything we tried. But of late, the latest one patient, when the lesion was not very bad, after the biopsy, the patient was put on, levofloxacin. Because in SNEC, one consultant said that they used to treat it with the floxacin groups. And he said some of them are responding. So the higher strength levofloxacin, we started him on. And now I am seeing periphery, the scarring started. And the density of lesion is also not increased and is not on steroid. So maybe, I have to see whether it really helps. And maybe Dr. Baga can comment on this particular question. Then I would like to say some points about these two cases.
Okay. Dr. Bhupesh, please.
Yeah, good evening. So the protocol which we are following at LVP for stromal microsporidiosis is usually the same as others. Like mostly it is like a surgical management. But recent past 2 years, we are trying something like as previously mentioned, voriconazole or fumagillin actually that and 3 or 4 cases actually showed some good response in those cases which are smaller and like there are 3 to 4 millimeter in infiltrate and they were in the anterior stromal. So those cases actually give a little bit of insight that why to do penetrating keratoplasty for anterior to mid stromal microsporidiosis. Why not to try medical treatment when there are enough evidence in vitro susceptibility about fumagillin and it has been used from years for intestinal microsporidiosis as a mainstay of therapy. So we tried it and it seems to be working for these 3 cases which are working, but still it takes long time and it is having a lot of other things that it needs to be stored and in cold chain to be maintained and it's little expensive medication and all these things are there. But if patient can afford and if you can manage to get this drug, why not to try? And particularly at present, I'm combining with voriconazole also. And patients recently, I'm managing a bilateral 76-year-old male from Kolkata having bilateral stromal microsporidiosis, but having difficulty in managing that patient. But yes, it is not to go for bilateral PK for that that old man and trying to this drug.
So for a person like me who is sitting in the periphery, what would you suggest to start? Would you recommend medical management to start with and go on with surgical, intervention?
I would say if it is anterior stromal and if it is like smaller, like which we call it in microbial keratitis, the mild variety, I think medical treatment should be attempted. And most importantly, not to go for misdiagnosis of viral keratitis and do not start steroids. And that is actually more problematic. And
actually, before they reach us, they are already on steroids. They are already on steroids.
Yeah, so I think so. If you stop steroids and start the medication, initial worsening is expected, and then slowly it starts going right. So I call it turbulence of enemy. So steroids.
There is a very nice, discussion going on the chat box that what comes first, like, is it the epithelial, microsporidial involvement, which leads to stromal involvement, or does it penetrate an intact epithelium? What are your, opinions about that? Any of you?
Penetrate. Yeah, I think Kurenti was telling something.
Yeah. See, just
infection stromal keratitis that we have seen, the epithelium is intact and the superficial layers of the cornea look relatively clear, and you see the infiltrate is located at a deeper level, and often it's misdiagnosed as viral stromal keratitis, and because it responds to steroid, and maybe they give oral antivirals as well, that you think that the patient is responding to treatment, and the patient is treated for some time and then sent back only for the patient to wax and wane as the steroids are. So the question is, like, do you have like 2 different species of microsporidia, one that predominantly causes the infection on the epithelium, what you see with rainy season, and you've got the coarse SPK, which is self-limiting, whereas you have another that actually penetrates and goes and resides in the stroma and starts an stromal infection there, which kind of smolders over a long period of time. And coming to the other presentation where DALK was shown, I would suggest follow-up, because there is a recent paper from Sujata Das where they have shown a case 3 years after DALK, patient presenting with endothelial rejection kind of picture, which when they didn't respond, they did a therapeutic PK, and the tissue showed presence of microsporidia at the level of the DM and the donor tissue. Even in one of my cases where I had successfully done a DALC, this guy was an ENT surgeon who had a stromal keratitis, and I did a big bubble DALC, and I thought I had cleared off everything. We treated him well, but 4 months later, he came back with a small infiltrate at the interface, which then, progressed. And despite giving all this treatment that we had given him, but we had to do a penetrating keratoplasty. So DALC, although it may sound, maybe for very early cases where the disease is superficial and you have made an early diagnosis, might work, but we don't know how deep the organism is penetrating. So currently, maybe a penetrating keratoplasty seems to be a much better option if you are dealing with microsporidia.
It is quite possible. The first case it happened. The second day we did DALC, but later persistent inflammation, KPs and other things. That's why I went in for PK, and she was doing very well with PK, but later she had unfortunately an injury. My point, what I wanted even to ask, the first case also bilateral, and both these patients are from Kerala during the rainy season, and she's a immunologically compromised patient, uncontrolled diabetes and all. So whether it could have started as epithelial keratoconjunctivitis, and because of the immune compromised state, whether it could have migrated inside. That was my doubt, because it was a bilateral case. And the left eye also showed those kind of nummular kind of picture initially. Later, this is the typical picture what we used to see, the granular or cloudy appearance of the stroma, especially when they are on steroid, very little inflammatory sign, and the opacity will be granular and cloudy. Very different from the regular viral keratitis, what we used to see. And viral keratitis, even stromal IK, once you start steroid, you will start either seeing scarring or it will clear off. So when this is not occurring with the steroid, then we have to think about microsporidiosis. Even in the next presentation, the first girl, she presented with kind of epithelial lesion only, microsporidial SPK kind of thing only. But later she lost follow-up, and after almost 1.5 years later, when she presented, by which time she was treated as viral keratitis in multiple cities. Then she came back. It was a typical mid-stromal, that cloudy lesion. When we tried to stop the steroid, immediately it flared up with a lot of intense inflammation. And then that's why we needed to go for a PK. And then we have proven with histopathology that it is a microsporidial infection. But luckily, so far, she's doing well with the PK. Maybe as Fogler said, a direct PK in such a case really helpful. But the second one was a very small lesion and only not even up to mid-stroma. That's why we thought we'll try DALC, and so far we crossed our fingers. Like he's doing okay, but I don't know how long. Like he may present later.
I saw one patient, few months maybe back, when the patient was from Gujarat and he was putting steroids for 1 year. And he had typical epithelial lesions with stromal lesions, and the doctor was giving steroid but also trying voriconazole and other medicines. And then when we stopped the steroid, the epithelium healed, but the stroma didn't heal, and it went on for quite some time. Although they were very small lesions, but finally, he got frustrated. So I sent him to LVP to do a therapeutic PK, and he has had one there. But so there were both the things together in this patient.
Ma'am, I think to answer Dr. Revati's question, I think some kind of neurotropism in the cornea can help these organisms penetrate deeper. So I had a patient with Hansen's lepromatous type, where he had decreased corneal sensation and he had bilateral microsporidiosis. So in diabetes, again, where their epithelial wound healing is delayed, and maybe this is a predisposition to develop to harbor these infections for a long time without the host immunity mounting any response to them.
Observation.
Also, the use of steroid during the acute phase of the infection, thinking that it is adenoviral keratoconjunctivitis, people would have treated with the steroid. Maybe that is also one reason why it penetrated deeper. just just I'm thinking like that.
Both the systemic and local immunity being disturbed, it seems. Yeah. Shall we move on to our next,
just one point, but sometimes when we scrape the superficial microsporidiosis for diagnosis purpose, the keratoconjunctivitis, seldom it leads to implantation or a stromal form. We've never seen it actually.
True.
Yeah, so maybe there is a point in what Rajesh said, that they two are caused by two different species of the same organism. Otherwise, we go and scrape it, we're bound to kind of implant a little bit, which never happens. Doesn't prove or disprove anything, but probably what he said is correct.
No, same thing. If you look at the incidence of or the prevalence of epithelial microsporidia, which is much, much higher than the stromal microsporidiosis. So if it was so simple that those things go deeper because of either topical or systemic immunosuppression or in any other ways, then the stromal microsporidia should have been much more prevalent than what we are seeing.
Exactly.
I think we are missing out a piece somewhere.
No, they've already published that among the 4 genus, 2 are present more on the epithelial keratoconjunctivitis, and the one which is there in the stromal is totally different. So when you read medical microbiology, they don't actually differentiate the pathogenesis, that is the virulence of these 2 differently. So they have a lot of literature in systemic microsporidiosis, but very little has been explained about its pathogenesis in the eye. Nosemia versus encephalotozoon. I think Dr. Ram Mohan will enlighten us more if in his talk.
Maybe we need to study this in an animal model. If you have different species of microsporidia, you can try to create or simulate an infection model, which will give us more insight. But because the infection is so rare, I think maybe the microbiologists or the scientists are not interested in performing, because it's not a huge problem in the community, as you see.
I think we will move on to our next talk. When we see these, confusing cases, and we really need some, clue from our, colleague. So we have, Dr. Ram, a microbiologist from Arvind Coimbatore, talking to us on how to reach to the microbiological diagnosis for microsporidial stromal keratitis. Dr. Ram, please.
Thank you, Paras. So, without much ado, I'll just put my slides up there. It should be quite self-explanatory, but the whole idea here is to have a, the basic overview of what these bugs are all about and what we generally need to know in the context of increased number of cases that are being seen, especially the stromal. So let me share my slides. Hello, where is my slides? There you go. So, can you see these slides?
Yes, sir.
And if I'm loud enough, I'll continue. So,
yes, sir.
Right. So, ocular microsporidiosis is our topic, and the slides on top, we're going to see them again in the next few slides. So, briefly, I'm going to cover the classification, a little bit about the life cycle, and what do we know about the genera and species and what we don't. A little bit of history with respect to the subcontinent. What are the types of ocular infections? I'm not going to go too much into the clinical because you have enough to say on that. And some of the trends and some transmission and risks that we suspect. And of course, the most important is the diagnosis part. So, right. So the first talk is the classification part of it. Now, this is Microsporidia has been one of the most talked about parasites in terms of their confusing classifications, reclassifications that has happened over the last couple of decades. So earlier, there was a suspicion that evolutionarily are these guys some kind of primitive eukaryotes because they lacked the mitochondria and the peroxisomes, etc. And in fact, they were at one time classified as protozoans. But since at least in the last 15 years or so, various studies, especially phylogenetic ones based upon various genes, but particularly the RNA polymerase large subunit, has shown that, what does it show? It shows that they are closely related to fungi and not to protozoans. So over here you can see the closest clade over here is the Saccharomyces and Schizosaccharomyces yeast fungi, and you can see there's an early branching from the primitive fungal clade. So what we know now is that these are not protozoans, they are fungi, and they are not primitive eukaryotes, but an early divergent clade of the fungi. And a couple of references in case anybody wants to go through. There's a lot of other studies also which have been done regarding the classification of these guys. Brief about their biology, and you would have seen some of these pictures if you, it's out there. What do we know is that there are these, what we call as spores. It's a biwalled, there's an endospore and an exospore, and within that is the plasma membrane. And this double wall characteristic is what gives its resistance and other, characteristics for these spores. This spore, this is the environmental spore we're talking about, not the spore that we're going to see in your gram stain or even in acid fast strain. So these spores, environmental spores, are quite varied in size, anywhere from 1 microns to 30 micron, depending upon genus and species. So briefly, the spore gets, once the epithelial barrier is crossed, the spore gets into the host cell and injects the infecting, which is the ejection apparatus, the polar filament, injects a sporoplasm into the host cell, and the sporoplasm does the rest of its life cycle. Two stages of the life cycle, one is the mirogony and one is sporogony. But in a nutshell, it forms a clone of itself, varied types of spores, and this becomes the sporoblast, and then it bursts out of the host cell and infects the neighboring cells, etc., etc. So these are what we call as the spores, which we see in, for example, in your grams or in your biopsies, etc. And these are usually in the range of 2.5 to 1.5 microns. It is also highly variable. It depends on the genus and species. Okay. Genera, right. So if there is confusion regarding the classification, there's far more confusion regarding the types of species and genera that are being described. Fortunately, most of these are being described relevant to invertebrate and other vertebrate infections and what is there in the environment. But they're formally recognized at least 1,300 species, wide variety of genera. It's quite ubiquitous, as we all know. Has a wide range of hosts, plenty of invertebrates and many vertebrates. Nearly all of them are known. All of these are known to infect animals, including commercially important species, and domesticated animals too. For humans, so far, we know that there are at least 7 genera and some unclassified, which have been implicated and proven to cause human infections. There is a zoonotic component to these fungi and how they jump onto humans, probably from some of these, animals. Predominantly, in the earlier descriptions were that these guys were associated with immune suppression, earlier described in HIV patients, etc. But we do know that, at least as ophthalmologists, we do know that a large number of our patients are immunocompetent. The genera, some of them were mentioned by Dr. Meena, and Nikhil also had a query on that. So the ones that we do know are the ones that are ticked over here are the ones which have been proven to be associated with ocular microsporidiosis. And these two guys, Vitiforme and Nosema, are the ones usually associated with the stromal keratitis, whereas encephalitozoon, earlier known as septata, is the one that has been described with the superficial keratitis. Of course, all the other 5 others have also been implicated in variety of human infections, rarely in ocular cases too. So they are opportunistic pathogens in immunocompromised. We do know they are seen all over, including the kidneys, intestines, etc. And next to the digestive tract version of transmission, especially fecal oral, is the ocular disease. So the second most important type of manifestation in humans is the ocular diseases. And there are 2 variations there, presentations of this. As described and going to be described more in the subsequent presentations, what is known as the superficial keratoconjunctivitis, MKC, and of course the deep stromal keratitis, MSK. What do we know is that there are more and more cases being reported in the last decade. I'm talking about specifically with respect to India and South India. And most of these, of course, are the superficial, but more and more stromal cases are presenting to us, including a few which are bilateral. Is there a seasonal trend? Yes, there seems to be, a bias towards more occurrences during the monsoons. And is there an endemicity? There are a few places, Thailand and some parts of Southeast Asia, where endemicity has been reported, but nothing, in detail has been published so far. Okay, so this is briefly to tell why we are here at this stage is because of this trend. And the first described ocular microsporidiosis case was the one described from Sri Lanka in 1973. But then within a few decades, we realized, and there was a first publication by LBPI group in 2003. And then subsequently, Sharma and Das in 2009 started warning us, hey, listen, there is this emerging, parasitic infections going on. Keep a watch out on that. And now, within a space of a few decades or so, we also had a study done on the PCR as a potential tool for diagnosis. So this is a trend from one of our hospitals, is that prior to the 2014-13, we had a few dozen cases. Of course, almost all of these were the keratoconjunctivitis cases. But a dramatic increase over the last 5 years or so. Other than this, artifact, maybe because of less footfall during the COVID 2019 to 2021, but the trend line still remains the same. And I suspect this year also we will get about a couple of hundred cases of keratoconjunctivitis and about a dozen or more cases of stromal. So as I mentioned earlier, 1973, but then now we have 2 clinical distinct forms of presentations, and more are seen in immunocompetent, and not like the earlier suspicion that things happens only in immunocompromised. And of course, cases of sclerouveitis and a couple of end-off cases have also been described. What are some of the risk factors or sources or modes of transmissions for these microsporidia? It's not yet very clear. We do have contact lens wear, breaching the epithelium via microtrauma. And of course, dust and insect bites have been reported. Close contact with domestic animals. But the largest indicator or the clue seems to be either the monsoons or contact with contaminated water. And as you all have mentioned, is that patients who have been hospital hopping for many months and maybe up to a year and under the various kinds of steroids, these two have been the two main problems, cases that turn up in our hospital. So why this now we come to the question of diagnosis. So why do we have to worry about this, or why is such a big problem? We're already seen in a couple of, at least 3 of these presentations over here is the varied, the clinical presentations that we have. It's a big masquerade. It can mimic various types of corneal infections, and often confused, the keratoconjunctivitis is often confused with adenoviral and other types of viral keratoconjunctivitis. And of course, MSK is the one which can resemble fungal, even acanthamoeba in some cases. So we have seen this wide types of presentations for the stromal keratitis. And therefore, both MKC and MSK are frequently misdiagnosed, but ultimately, the clinician must have a high index of suspicion to include microsporidia in the differential diagnosis. Why that is important is because the next thing that we need to do is how are you going to diagnose it in the lab? So the most commonest or the best identification method that we currently use is the microscopy, which is the light microscopy. Routinely, the routine microbiology, especially the gram stain, etc., have moderate sensitivity and specificity. Most of the time, it's subjective. It turns out it can require a little bit of expertise and training in checking these gram stains because of the high variable sizes of the spores and variable staining that happens. And of course, we cannot determine the species via any of the staining methodologies. So a rapid, sensitive, scalable technique is capable of being used for identification of a human pathogenic microsporidia to the species level, practically, both clinically and environmental sample, has been lacking. However, the PCR, using a variety of primers, has been useful not only in identifying them, but also the identification of the genus or the species. Okay, so light microscopy. So what are the commonly used techniques that we do? And all of these have been found useful for conjunctival smears or corneal scraping. The gram stain seems to be useful in identifying most of the time. And in a study done by Joseph et al. In 2006, they have shown that more than 90% sensitivity for the gram stain. But however, you can see the picture on the left. And this is a gram stain showing the spores that we see in microsporidia, suspected microsporidia. And this can be a problem because the variability in size can often confuse it for a gram-positive, large gram-positive cocci. But then the dead giveaway is this type of morphological arrangement. And we also saw an earlier slide in one of the presentations where there was a fatter oval type of spores that was seen in gram stain. So there's a great variability in the degree of staining as well as in the size of these spores. Unless you have a large number of spores, non-experienced microbiologists can just mistake this for a gram-positive cocci. And therefore, clinical suspicion needs to be high and it needs to be informed to the microbiology so that we can look for these guys. Second, of course, is the modified or the modified AFB, which is used. So this will be the second most common recommendation for corneal smear in the case of stromal keratitis. Calcophore white. So we have talked about it, and I know Shankar Netralia and a few other places routinely do the KOH plus calcofluor white, but this requires a fluorescence microscope. And to answer the question of which of these methods are going to use for a peripheral center, the gram stain works well. If you're going to take double smears, I would recommend you do a modified AFB also because of the good degree of contrast you get for visualizing these bugs. If you're in a tertiary center or have a facility for fluorescence microscopy, the KOH plus calcofluor white works extremely well. And we have seen a couple of those pictures in the Shankar Netralia presentations. So this picture over here is the calcofluor white, and you can see a dark background with nice fluorescent light blue, whitish to light blue calcofluor white. And this is primarily because of the presence of chitin in the cell walls and the spores of the microsporidia. But what is the problem with this? I will give you some of the issues with that. Of course, it is time consuming because it takes some time to search for these and etc. Second, of course, we require a lot of some amount of experience, and if you don't remove your debris, you can get confused. A lot of artifacts and other types of gram-positive looking appearances over there. One problem, of course, is that scrapings are a little difficult for the deeper stromal keratitis, and very often there will be nothing in the smear because you're unable to scrape deep enough to show some of these bugs in your microscope. The PCR is the next one, which is not, it's expensive. It's not currently used as a routine diagnostic in any of the hospitals today. It's currently used only in studies, but briefly, I can pick up any small amount of the DNA from the scraping or even from a smear. You can even use a swab in the superficial cases and send it in the saline or saline. And they use primers, typically two types of primers. There, of course, is a pan microsporidia primer which is used. But specific primers are always encouraged, and the commonest one for the Vitaform and for encephalatozoon primers can be used for the PCR. A variation on this is Cybergreen real-time PCR, which works extremely well for individual Microsporidia species. But then this is not easily available and is quite expensive. Histopathology. So now cases which have undergone therapeutic keratoplasty, send the buttons, works extremely well. At least post keratoplasty, you can confirm your initial suspicion or your diagnosis. And the commonly used smear stains are hematoxylin eosin and modified trichome, although GIMSA also works quite well. And so on the right side over here is a H&D biopsy showing the typical rice grain clusters. And there were some other pictures from the other presentations. You could clearly see these going in the line parallel to the lamellae. And those are usually dead giveaways that this is Microsporidia. And we do have immunofluorescence methods, but it lacks, limited specificity. Some of the other stains that are used and work well, and a good study done by the LBPI group a little while ago, is that other than the H&D, the trichome works very well, and of course the various fluorescents, including acridine orange and caterflow. And right at the bottom over here is a modified AFP, showing the nice oval, pinkish oval bodies against a light blue background, depending upon what is your contesting. Serodiagnosis, I'm not going to go too much into this, but you can do serology like you will do in ELISA or something like that. But the antibodies for a wide variety of these species are not available. And, it's not a reliable test and it's not available commonly in India. Cell cultures, and as we know, I think it was Rajesh Fogla who asked this question, is that why are you microbiologists not doing anything about understanding Microsporidiosis in a lab or an animal model? To answer that is the same issue we're having with Acanthamoeba, is that it's very difficult to work with these guys. They require tissue culture methods. Standardizations are difficult. Maintenance, I suspect it has to be done. But then there are, of course, practical and scientific issues why working with the protozoa or parasites are very, very tricky. And therefore, no studies have taken place so far. Confocal, I'm not going to go into this. I suspect the next speaker and subsequent speakers are going to talk in detail about it. But this is a non-invasive method. We know that it's, non-invasive with high magnification and good contrast. And for those people who do have a confocal microscope, this will be an extremely good first-line screening tool, because you could see, for example, in MKC, you will see rosette-like clusters, hyper-reflective pinpoint oval intracellular bodies. In the stromal cases, we tend to see a similar one. For example, over here, tend to align along the lamellae. ASOCT, I'm not going to go into that, but recent study has shown that it may be a good guide, especially under treatment, the prognostic. Thank you.
Thank you, sir. The extensive lecture it was, but it was so informative. Now I would like to request Revati madam, please, can you please show the confocal typical slide which you wanted to share with us?
Yes, madam. I hope you can see this.
Yeah, yes, madam.
This is a patient because the patient is a HIV positive patient. So the typical what they have been talking, that fluffy cotton wool kind of thing, multiple lesions in the stroma, and the confocal, because it's uniqueness, like no inflammatory reaction, and you can see the multiple rice grain things, like the rice grain bodies. So in histopathology we are seeing, you can see along the stromal lamellae, and I mean they are just clusters. So this is the typical how we have to see in confocal, but not in immunocompetent patient. It may not be this much so obvious, but since it is so obvious, that's why I thought I'll share this. Otherwise, what Dr. Ram Mohan showed already, it will be like that only. Like the second picture where you can see small suspicious thing we can suspect. But here, because of the immunocompromised state, you can see like real big ones all over, in all depth, up to the almost as like endothelium. You can see to the Desmond's level. You can see the organism going. This is one reason why they kept on telling lamellar keratoplasty may not work. That even some cases of deeper infections also have been reported. So just I want to share this typical picture of a confocal. Thank you.
Ma'am, was it a bilateral infection?
No. In this case, it was not bilateral. Unfortunately, the patient just disappeared after the initial presentation. We advised her straight away the keratoplasty because of her condition. And we wanted to get the physician opinion regarding her status, but after that, the patient didn't turn up.
Thank you, madam. We'll go to the next presentation from Disha.
We've all seen movies where the detective keeps looking for the villain, thinking he would look different, only to realize that the villain looks like no one in particular. Today, we're going to discuss about one such villain called microsporidial keratitis, which either looks like everyone or no one. Good morning. I am Diksha Thorat, a first-year cornea fellow, and I'm going to take you all through a case of microsporidial keratitis, a diagnosis often missed. A 59-year-old gentleman came with complaints of recurrent episodes of pain, redness, and watering in his right eye since the past 2 weeks. He has a history of similar episodes earlier, for which he had consulted several ophthalmologists and had used various medications. Once the medications were tapered, his symptoms would recur. So the slit lamp photo shows a paracentral area of ulceration with underlying dense grayish-white stromal infiltration with irregular and diffused edges. The corresponding ASOCT showed mid to posterior stromal involvement. Corneal scrapings were taken and revealed Microsporidia spores in both gram stain and 10% KOH with 0.1% calcofluoride as shown here in the circles. Therefore, the diagnosis of stromal microsporidial keratitis was confirmed. Management options of medical therapy with topical fumagillin and voriconazole versus surgical management were discussed, and in view of long-standing history and inability of frequent follow-ups, the patient referred to undergo surgery. A good quality tissue was selected and trephinition of 9.5 into 10.5 mm was executed to include the affected tissue. 3 surgical PIs were made and the graft was sutured with 16 10-0 nylon interrupted sutures. The patient was seen on the next day and the graft was clear. Subsequently, he followed up after 1 week with the referring doctor and no recurrence was noted. Meanwhile, the corneal button was sent for histopathology. The images in this slide show the corneal button with ulcerated area and the stroma showed intense inflammation involving all the layers. The spores were noted even in the deeper layers of Quignon's preparation. Although this villain hides unsuspecting in our cells and stays dormant for a long time, here are some pearls we learned from this case that can help towards early diagnosis. Microsporidia is a great mimicker and typically is misdiagnosed as viral keratitis, keratoconjunctivitis, or fungal keratitis. 10% KOH with 0.1% calcofluoride are simple and rapid methods of diagnosing microsporidial spores. Cases with deep infiltration should be rapidly undertaken for penetrating keratoplasty with necessary precautions. Thank you for your patient listening.
Yeah, excellent presentation from Disha. Now we'll go to the last presentation of the day. I think Sweta is ready. Sweta's slide.
We have 2 more.
Oh. Yes.
Good evening, one and all. I'm Dr. Shweta from SM. I thank CSI for this opportunity. We had a 66-year-old gentleman with redness, irritation, and decrease in vision for 6 months duration. He was hypertensive and on thyroid disorder and did not have any other systemic complaints. He was diagnosed to have left eye keratitis and was already on steroid eye drops 4 times a day for almost 2 months. This was his picture on initial presentation with peripheral guttering infiltration surrounding it and AC quiet. He was scraped to rule out an infective pathology, but smear did not show any organisms. Blue and BCL was done for the peripheral ulceration and was started on antibiotics with the working diagnosis of peri-PUK with an infective cause. His other eye was completely within normal limits. On day 3 of presentation, there was no growth on culture from the first smear, but there was worsening of the infiltrates and KPs were seen on the endothelium. Decision was made to re-scrape him with special stains as well with modified ZN stain. But still, there was no organism seen on the smear. Clinically looked infective, not convincing as immune-related PUK. So patient started on fortified cefazolin and 0.5% garifloxacin eye drops. Differentials being microsporidia considering the fluffy stromal infiltrates, still PUK and HSV-related keratitis. PCR for HSV was also sent. PCR being negative with worsening of infiltrates, we made a decision to go ahead and scrape a 3rd time because the infiltrates were worsening and the peripheral guttering was also increasing. The 3rd scraping showed microsporidial spores and he started on hourly PHMB eye drops and 1% voriconazole eye drops. This is a picture showing the microsporidial spores in calcofluor white and 1% acid fast. PCR from this sample was also positive for vitiformicani. He underwent glue and PCL with AC formation on day 9. He was advised to continue the topical medication. Steroids were still withheld. At review at 3 weeks, he was non-compliant with medications with worsening of infiltrates and exudates in the AC with perforation. Here he was advised to undergo a patch graft. He underwent a 6 millimeters patch graft at day 35 from presentation. His microbiology button did not show any microsporidial spore, but PCR was positive for vitiformicani. Histopathological examination, however, was not negative for any pathogen on multiple stains. Corneal stromal infiltration with acute necrosis and mixed inflammatory cells was noted. This is a PCR report from the corneal button, which showed the molecular weight ladder, negative control, positive control, and our patient's sample positive for vitiformicani. In-house sequencing was also done to confirm the diagnosis. So this is a sequence of events from his presentation to the patch graft. At 6 weeks post-op, patient is doing well. He is awaited for his clinical examination. Take-home points would be decision to rescrape based on our clinical judgment and to ask for specific modified stains when we have the suspicion of microsporidiosis. And also to keep in mind, 29.1% of microsporidiosis can present as ulcerative keratitis. Thank you. Special acknowledgement to our L&T Microbiology Vision Research Foundation.
Yeah, next we'll go to the next presentation. Last.
A 70-year-old male farmer came with history of trauma to right eye while working in the field with subsequent redness, pain and diminution of vision. He was on topical antibiotics and antifungal medications when he presented to us. On examination, the vision in the right eye was PL positive with a 7 by 6 mm full thickness corneal infiltrate with endothelial exudates and a PCIOL in bag. There was evidence of vitritis on B scan. Corneal scraping revealed presence of gram-positive cocci and no fungal filaments but no growth on culture. In view of worsening, in spite of treatment, a therapeutic keratoplasty was performed and the corneal button was sent for microbiology and histopathological examination. Culture of the corneal button revealed Streptococcus viridans. We started our patient on topical vancomycin 1 hourly, natamycin 6 times a day, ciprofloxacin eye ointment and hometropin eye drops. There was a resolving vitritis that was noted. On histopathological examination by our ocular pathologist, granular ovoid cellular refractile structures were seen between the stromal lamellae suggestive of microsporidial spores. The suspicion of microsporidiosis was confirmed with special staining by Mason trichome stain. The organisms could be seen as dark red against blue background. A recurrence of infection was noted at the graft host junction from 7 to 10 o'clock on post-operative day 5. We added a tablet itraconazole 100 mg, topical voriconazole and chloramphenicol eye drops 2 hourly, post which the infection resolved and the patient became symptomatically better. He maintains a clear corneal graft and a normal posterior segment. Thank you for your kind attention.
I think we have come to the end of the presentations. So we'll take up some questions on basis of the feedback which has been given. So Paras, can you please?
Yeah, in fact, we have Dr. Savitri Sharma on panel.
Okay.
Madam, can we have your comments on microbiological, diagnosis of these cases? Because most of the time we miss it, and it is missed as, in some of the cases as gram-positive cocci initially. Probably that could have been, it was missed and it was not diagnosed as microsporidial infection.
Good evening, everyone. Actually, I believe very much on the KOH and calcofluor white preparation, because there even one spore will be very clearly visible and cannot be confused with anything else. Unlike in gram stain, as you rightly said, it can be mistaken for gram-positive cocci unless you have seen intracellular and many of those parasites together. If they are there in a clump, then you can be sure that they are microsporidia. So it is calcofluor white, fluorescent oval organisms are very, very clear. And I believe really in that method. The other one, I think Dr. Ram Mohan presented very well and very extensively. He has given he has quoted our references very nicely. The one point which I could add was the stromal keratitis, you find bigger size of the spores. It's happened to me many times, even to the extent that some of them may look like the candida size, quite big they look. Compared to keratoconjunctivitis, where always you find very tiny ones and very thin ones. Somehow they are very fat and well fed, they look in stromal keratitis. And also in stromal keratitis, because of long-standing ulcers treated with steroid for a very long time, sometimes the cultures will become bacteria positive. And you may be mistaken that you will be going towards bacterial keratitis diagnosis, but you have to again look very carefully only in the smear. The microsporia does not grow in culture, so you are never going to find it. And
like in that last case which was shared, ma'am.
always smears. You have to be very, very in ocular microbiology, there's no replacement for direct microscopy. Majority of the diagnosis, especially in keratitis, we make on the direct smears. So one must pay good attention to that and not be misled by the findings in the culture, because superadded infections are common in stromal. It doesn't happen in keratoconjunctivitis. All keratoconjunctivitis cultures will be sterile. You will not find anything. So these two were the points which struck me. Otherwise, Dr. Ram Mohan has covered everything very nicely. Very nice cases also. I've been glued in the beginning of the presentations. Thank you so much.
Thank you, Savati madam.
Thank you, madam.
I want to ask you, the calcofluorescence and all, it's all basis of the type of microscope you are having. So periphery people won't have this high-end microscopes. So for the basic people who are going to do this scrapping, what is the...
They have to learn the gram stain. They have to learn to recognize in gram stain.
Yeah, exactly. So I entirely agree with what...
Dr. Das, interestingly, one of our microbiologists picked up Microsporidia on saline and KOH preparations, and I was quite amazed to see that. That you can such tiny organisms you can
add
pick
to
up
this?
on. Yes.
Paras, can I add to that?
Yes. Yes, sir.
Yeah. Hi. Yes. So, Dr. Savitri, our guru, how are you?
Thank you. I'm fine. Thank you.
So
good
all the points, yes, good to see you, madam. So all your points, I just want to give another insight to how we can manage this confusing issue of nothing showing up on the smears, but your suspicion is quite high and you're in a peripheral setup. So a couple of things is that, of course, the best method will be the calcofluor. Now, some of you had a doubt that we do the standard KOH and look under the slide. This can be done, but there is a catch. Very often, it's difficult to get much out of your scraping. So if you're going to be a peripheral center, don't waste it on a KOH. Not talking about calcofluor, I'm talking about a standard KOH wet mount. That's an utter waste. Do a grams, or preferably take 2 smears, one for grams and one as a backup. All your smears, please don't do the standard, heat fixing methodology. And this is something that we have all been taught for many, many years. And once you heat fix, you just can't do anything with those slides afterwards. So whatever smear you take 2 slides, methanol fix them, right? And you can do a grams, primarily because our first suspicion is that, could this be anything? It's a big masquerade. It could be fungal, it could be bacterial. By simply doing a Zeal-Nielsen or something else, you can miss out on what could be the other microorganism which could be causing your, especially because of stromal microsporidium has a variable presentation. So don't waste it on KOH and don't waste it on other smears. The second slide, you can use it for some other better staining methodology. You can use the modified AFB. This works extremely well to differentiate. However, if your suspicion is still very strong only for Microsporidia, do a GEMSA stain. Why the GEMSA has advantages for you is the GEMSA also shows you the cellular types, which none of the other smears are going to explain to you what are the cell types or what is the response in that particular eye. So if it's going to be a microsporidial, for example, it'd be more neutrophilic. If it's going to be viral, it's going to be mostly lymphocytic, etc., etc. So a cell type will give you a clue also what is happening. Second advantage is that Microsporidia stand out very well morphologically in the GEMSA smear also. So you're going to be in a peripheral situation, do a grams and back up with another slide, both methanol fix. And if your suspicion is still strong after a negative grams, do a GEMSA for your second slide. So this is my recommendation for a peripheral center, and some cheating methodologies how to fix your slide. Why do we have to do this by methanol? Is that you can always restain those slides if you methanol fix it. If you heat fix, you cannot do anything with it. You can just chuck those slides. So with methanol fixing, it's easy to destain those slides, and you can restain by other methodologies. I do it quite frequently. a lot of advantages in methanol fixing a slide. A gram stain can be restained. So we have had situations where only one smear has been there and have restained those grams and found other bugs by methodology. So these are some of the, simple steps that you could take if you're going to be in a peripheral situation. If you're going to have a tertiary center with a fluorescence microscope, of course, the first will be a wet mount doing a calcofluor white for these smears, because the calcofluor also shows fungi and other things also. So it's a helpful slide. And then, of course, the other slide has to be a gram stain. So this is what I will generally recommend. Second, of course, is the question of streptococcus or another bug growing in your culture. It happens very often. We are seeing a wide variety of mixed infections in our microbial keratitis. In these particular cases, as Dr. Savitri Sharma told, long-standing, deep infiltrates, a lot of opportunity for secondary infections. So you have to don't think it's a contaminant. And Streptococcus viridans is not a contaminant. So don't worry if you see another bug going on your culture. It can happen.
Thank you, sir. Thank you so much for the nice inputs.
Can I ask one question to Dr. Bhupesh? Dr. Bhupesh, you have been using fumagillin. So what is your experience of, using those drops in this stromal microsporidiosis, and any other methodology have you been trying? Like you are playing with those other toys, like maybe trying CXL or applying cryo or any other methodology to, take care of such cases? Dr. Bhupesh, are you there?
So, yeah. You can hear me?
Yeah.
Can you hear
Yes,
me?
Yes.
Yeah, so I tried PDAT in this, but did work for that particular patient. And after that, I didn't try for any other case. So one case only I tried, it didn't work. Initial showed some response, but later on, as microsporia, we know it's like intracellular and goes on beyond the level of 220 microns, which is the area where the PDAT works. So it didn't work, and we finally landed into PK. Regarding topical fumagillin, as I was writing in the chat box also, so I given 5 patients. Out of them, 2 actually responded completely, resolved. So one patient took almost 6.5 months of topical, initially 2 hourly, and then later on 6 times a day continuously.
How expensive that drug is, and is it easy to get?
Yeah, so the drug is not very commercially available. So it has to be ordered online, and then we have to be prepared in the lab. Like Dr. Savitri, when she was here, we prepared a little stock solution, and then we were using it. But it can be easily prepared. It is described as in the literature also, the percentage, I think 70 microgram.
So it seems it is not within the reach of the practitioners easily.
So if it is not. But if it is like, because it is not a common organism, that's why it is not. It is not to make it, and but yes, it is. It can be made. It is not very big rocket size. We can make PHMB chlorhexidine also, so we can make this also. But the only trick is to store it. Basically, to store in the freezer and then freeze to use it. So usually I give to patients 3 drops, 2 kept in freezer and 1 in the fridge, and they have to use it for at least 1 month. Those 3 drops usually are okay, and 1 drop usually charge around 2,000 to 3,000 per
yeah,
vial.
it is expensive.
Yeah.
One question there, Bhupesh. When you say 5 out of 5 patient, 2 patient it work or something. Well, similarly, then we all have in our hand different things like voriconazole, and those things also show such kind of resolution where some cases it may work. So how sure, unless we have a model where we show that it's like sort of working in more number of cases than not, then certainly it's worth looking for the further.
Yes, some kind of a standard protocol for these cases, you know, I mean.
Yeah, Bhupesh, you were saying something.
Yeah, so Dr. Himanshu, actually, this recently means past 1 year only we started this, and the cases are not so many, are mainly, and many are coming are in a very advanced stage of a whole history of 2 to 3 years. So inclusion criteria is to basically come around 3 to 4 millimeter size and entry to mid-stromal. I am trying this, and patient should be ready to come for follow-up for 3 to 4 months or 4 or 5 months and not willing to go for immediately. We also think that this patient is having 20/40 vision. Why to go for a transplant so early? So in those cases, and that was the only case we started, like after corona, that patient developed microsporidiosis, and then we started, and the patient responded well, and then after encouragement of that, we started 2 more patients. Also, those patients also responded. One still going under treatment. So that was the limited experience, but yes, protocol, I am still trying with voriconazole because that is another drug. But if you see the in vitro susceptibility is, fumazine has a very nice in vitro susceptibility against Microsporidiosis.
So I would just like to ask Anita, any comments or inputs you want to add at this juncture?
Yes, sir. Like 7 different cases from the beginning we have seen, like firstly I felt more of like presentations were like more of whitish colored, and then later there was so much of necrosis in the in the cases, and so many different associations also. So like the long-standing ulcer, the clinical the condition like this, why it has not been like why there is no like more of the anterior chamber or endophthalmitis was not there, and in the associated with this condition, and so many questions are coming to the mind whether there is a long-standing viral will be like will have some vascularization, all those things, and here there is no vascularization, and even the perforation is very less with microsporidiosis. Literature also has shown very less number of cases, 1 or 2 maybe with because it is so long standing, has a very long course, like 2 years, all those reports are there, but there is no perforation. But that seems like because the patient is already on topical steroids also, why these cases are not going for active necrolysis and those perforations, I don't understand with this microsporidiosis. I have seen very few cases in my clinics. Maybe I would have missed a lot. That is what I am learning from this webinar. Like so much of because this small lesions will they respond very well to the topical steroids, and then if we stop again, there is some recurrences, like there is a increase in the symptoms. I feel like for every case of viral which we suspect clinically, we should go for a PCR. That should be main mandatory, I feel. So many cases we just clinically diagnose and treat. So I feel like we have to do a PCR like what we do for a fungal or a for a bacteria. It's better that we do a viral PCR to rule out viral or microsporidia. So like because of lack of awareness, maybe we are missing so many of microsporidiosis also. And I see like in literature also so many cases, like they have now reported along with the microsporidia and viral also. So that is also there in the literature. So we need actually to do I think a multi-center study or something to bring about a standard protocol. That is our responsibility, I feel.
Madam, can you please add?
Yeah, one thing we should, I think this is a parasitic infection. Perforation is not common even in acanthamoeba. Though it may go on and on for months together, you can see even scleritis and all those things. It's very rare to see a direct perforation unless, sometimes I feel maybe a secondary infection when it occurs. So a parasitic infection, how it behaves may be different from a fungal or bacterial infection. So that may be one reason. So they very slowly progress. And I still feel viral keratitis is still more of a clinical diagnosis. And we have to have a high degree of suspicion when we don't get a response to the antiviral and steroid therapy as we expected. When either it should scar or it should clear. If it is a disciform, it should clear. Or if it is a stromal, it should IK type, it should go for scarring. So if both are not occurring, the lesion looks almost similar, then we have to suspect something else is going on. Or even acanthamoeba we have to keep in mind for that matter. So the high degree of clinical suspicion is more important in these cases because especially Microsporidia stromal, still very rare condition. So it's not easy to go for a large scale study or anything at this juncture, I feel. But a high level of suspicion, maybe that is why in some centers they are seeing more cases because they suspect more, they go for it and they are picking it up. So the awareness, I feel because 2-3 times whenever I went to Kerala, their local society meetings, I presented these cases. And after that, I started getting many referrals from Kerala when if this their viral keratitis is not behaving as they expect, immediately they refer. And we are picking up those cases as Microsporidia. So I think this will be very helpful and this should be the take-home message.
Thank you, madam. Thank you, madam.
And we also need a good microbiological setup.
Yeah, so sure enough, yeah, you need a good microbiology setup, but some of these things, basic gram stain, like Dr. Savitri said, is that you need somebody who needs to day in, day out do a grams, and majority of your diagnosis can be done simply by doing a good gram stain. It shows you a lot, but then, you gain experience over a period of time. Yeah, you need a microbiologist, but you can, some basic light microscopy. I think every cornea person should get to do at least a gram stain. It's not too difficult. So a lot of clues from your slit lamp and then of course your gram stain, and you can work quite a bit with that. But to touch upon what Dr. Revati said, yes, that same algorithm works whether it is Microsporidia or acanthamoeba. We have seen that, and our study has also shown that the acanthamoeba presentations are not what is in textbook presented earlier, which are mostly from contact lens microabrasion kind of infections. So we do see a wide variety of clinical presentations, both in Microsporidia and acanthamoeba. And we do get quite a few mixed infections in these cases. And we also know that it's a very slow, insidious process and rarely perforate into the cornea. And last but not the least, what many people have told is that if you're going to do a plasty, please do the entire thickness. And keep in mind that these guys go to the periphery or deeper and hide over there. And we have had cases of, graft, coming up, flaring up in the graft afterwards, both in acanthamoeba and a few cases of microsporidia.
Thank you, sir. Thank you so much for your points.
Since we have overshooted the time, Dr. Das, shall we just wrap up this session?
Yeah. Yes.
Or do we have some few more comments from anybody from the panel or anyone? I think we have had a great. Yeah, please,
yeah. No, just as Dr. Savitri told, when we were doing fellowship with the Dr. MS, it's a must that we had a microscope there, and it's a must that we have to do the smear examination first, slide examination, before sending it to the culture or something, asking for a culture plate or anything from the lab.
Yeah, actually, I wanted to say for Microsporidia, you don't need a microbiologist. You just learn to see the smear because it doesn't depend on culture at all. It just
absolutely. And yes, and I would first strongly recommend that it's time for microbiology and cornea to be married. The big role, absolutely. And many of our cornea fellows and PGs, half the time they are in the lab. And we have a number of cases. Dr. Revati knows that many of the cases, they track it starting from the slit lamp all the way through microscopy. And, once or twice they have called me and told me, sir, this is a cyst and this is whatever it is. So, so it's I think it's many of the basic things can be done by, as Dr. Savitri said, a simple gram stain will help you a lot, especially for the large bugs and typical ones like Microsporidia or hyphae, etc.
I think nowadays, keratoconjunctivitis, you don't even do smears. In Bhubaneswar, they have a tendency just diagnose clinically. It is so clear clinically that you don't really need smears for the keratoconjunctivitis. Stromal one, you still need to have some backup and some proof for that.
Yes.
Thank you. Very nice.
Thank you.
I think we will just, because we have overshooted the time, because we had wonderful cases this time. We just diverted from our 4 cases, selection to 7 cases. And we had a microbiological talk also included in this session. So all in all, it was a wonderful session with a lot of learning. And I would like to thank especially the chief moderator, Dr. Manoranjan Das, all the panelists, and the presenters and the audience for staying with us for such a long time. And I think we can, continue this for some, other session also, because this is a new entity which we are seeing and we are not able to recognize it early on. So we see these cases in a very late presentation, as we saw through all the different cases which were presented during this whole session. And I'm sure this would work as a, resource material for most of us to, go and look back and, understand our cases. So with all the, I would like to, I would like to thank everyone for being here so late. Instead of being 1 hour session, this has kind of, dragged on to little more than that. So I think it is a dinner time for everyone, and we would, I would wish, good night to everyone and look forward to next meeting for next, in next 2 months.
Thank you. Thank you all. Thank you, everyone.
Thank you.
Thank you.
Thank you, everybody. Thank you so much.
Those who are not
Thanks, everyone.
registered for KERACON, please remember today is the last day for early bird. So please go ahead and register.
Shabina, can we have one picture with all the panelists and all the, Can you put on your videos, the presenters as well? Quick, so we can have a quick picture and then maybe probably we can,
Sure, done. Thank you.
Thank you.
Thank you. Thank you.
Thank you all and good night.
Thank you, everyone.
Thank you all. Good
Thank
night.
you, Paras, for
Yeah.
having me. Thank you.
Thank you, Paras.
Very nice.
Thank you so much. It was so nice.
Thank you, Meena.
Really enjoyed.
It was more like, we always sitting in one room and discussing things.
Yeah.
Really. Thank you.
Thank you so much.
Thank you, madam.
Thank you. Thank you.